we'll go to the next talk by in this divergent world who has got organized a cardio convergence. That's a remarkable meeting. So let's invite Dr. Rakesh Gupta. Is he? Yeah, Dr. Gupta. So he'll be presenting on can we predict atrial fibrillation in elderly population.
Well, everybody talks like how to control atrial fibrillations. Well, many of us can go into atrial fibrillation, and that's what I'm going to talk about in next 10 minutes or 8 minutes. Well, this is one paper which was published almost 20 years down the line. Look, what this paper suggests, if you have a grade 3 diastolic dysfunction, the chances of development of non-valvular atrial fibrillation is pretty high. This is grade 3 and this is grade 1. Very simple basic phenomena. And this is the prevalence of atrial fibrillation in heart failure with preserved ejection fraction in various trials. What does it mean by if we diagnose heart failure with preserved ejection fraction, we are able to predict, like, can we predict this person is going to atrial fibrillation? Let's start with this study from our own center. Patient 73 years of age, normal sinus rhythm at the present moment, thickened mitral and aortic valve leaflets, dilated LA, eccentric LVH, and mitral annular calcification. Look, everything which is related to her aging process. When we looked at this, she has a dilated LA, index LA size was 23 and normal is 22, and she belonged to eccentric hypertrophy. Now look at these findings of echocardiography. If you look LA and RA, they look almost equal in size. Normally, LA is bigger than RA in size. She has annular calcification, and when went on to do a diastolic evaluation, she belonged to grade 3 diastolic dysfunction with all the parameters available in JACE 2016 guidelines. When we went on to do a LA strain for this patient, and once we did an LA strain for 4-chamber and 2-chamber, and then we realized, look, the LA strain for this patient is almost reservoir strain is only 10. Conduit -7 and contraction is -3 only with a large LA of 75 ml. So what was the diagnosis? We said, look, this patient belongs to a possible category of heart failure with preserved ejection fraction. As RA was dilated, we did suspect intermittent atrial fibrillations. Now look at this rhythm of LA strain. This is patients, this is normal, reservoir. Conduit, this is normal, what the patient has. And this is contraction, what is normal and what is the patient has. Significantly reduced LA with large LA volume. And that's where this paper comes up in JAC 2021, prediction of AF in heart failure with preserved ejection fractions. What this paper says, if I really get to the side of this paper is, look, if I'm putting this algorithm together, and before then this is algorithm of prediction of atrial fibrillation in heart failure with preserved ejection fractions, and I put my values into this algorithm. Look, peak atrial contraction strain, my values are what? My values are -3. And if I take on this value of -12.7, 30 people out of 72 will develop atrial fibrillations. If I take this value more than 17% or more than 12.7, even if I go to this side, out of this side, 8 out of 18 will develop atrial fibrillation. If I take this value as close to 12.7 or less, almost 30 plus 8, 38 out of 90 people will develop atrial. Almost 50% people will develop atrial fibrillation just based on this data. And that's what exactly the answer is. The peak atrial strain, the contraction and longitudinal strain, if you do in patient with heart failure, preserved ejection fraction, you're likely to predict atrial fibrillation, which person is going to what category in a time to come. Means to say that we have to be more aggressive in treating these patients rather than talking a debate on rate versus rhythm. And management is more difficult rather than prediction. Then second is left atrial chain predicts incident atrial fibrillation in general population in Copenhagen study. And if you look at this study says very categorically, look, these people, if I go to straightway to in general population, these two stain, they independently predict atrial fibrillation. And these findings remain consistent even the participant with normal size LA. And often we ignore when we often see a normal size LA in AP dimensions, we say this patient looks to be normal. And that's what next take home message is. Well, all of the time we are developing an acute myocardial infarctions. Many of these people subsequently they go for a remodeling for their LV functions. Can they be we predict atrial fibrillation in this kind of populations? Well, this is positive to say that again reservoir stain obtained by two-dimensional spectral tracking is independent predictor for atrial fibrillation following STEMI. Means if you are looking at STEMI patient, my colleagues, majority of them are interventional cardiologists. Once we do this kind of a thing, we should always look at their LA function subsequently. Finally, coming to last case, here is another case. She's just 90-year-old lady. She has got thickened calcified aortic valve leaflet. LA appears to be dilated. And here are the images of this particular lady. LV function, absolutely normal. Now look at the diastolic function. Diastolic function again shows reduced or elevated LVEDP, reduced GLS, and again coming down stain, she has got significantly reduced stain in this patient. And finally, if you look at the report, there are 4 findings which are talking about this: dilated LA, raised LA volumes, reduced reservoir stain by LA stain, intermittent tachycardia seen during study, and that's what is an important phenomenon. Look, during study the patient was having tachycardia intermittently, which we recorded. And finally, this says this LA stain predicts subclinical atrial fibrillation detected by long-term continuous monitoring in elderly high-risk subjects. If you happen to think that something is wrong is happening with your patient, don't hesitate to go for ELR is available in our country for at least 7 days. And that's how we can really predict these people. I'm not going to go into detail of this particular study, but look at the reservoir stain in subclinical atrial fibrillation, both up and lower down. This is what is happening, what is present in the literature. What more we can do? And this idea was given last night when I was sitting with Dr. M.K. Das. We have been doing hyperdoppler for a long time, almost for last 10 years. And this hyperdoppler we were utilizing for looking at the systolic and diastolic function of LV. Why can't we use this hyperdoppler in LA size to look how the eddy currents are happening in LA in heart failure with preserved ejection fraction? And I'm sure this is going to make a lot of difference if we look at an LA function. By looking at this hyperdoppler, I'm sure one of the company who is a Isorte Asia Pacific is right over here, and they are a pioneer in doing this work, which is done without using any contrast material, could be a next step in looking at this atrial fibrillation, atrial function. Thank you very much for your patience hearing.
Yeah, so I think first of all, it's a very apt topic, and you have clearly shown that you can predict it. So that is the where $1 million investment should be there, because if you predict it, you can treat it early. And what Dr. Tripathi also said, that if you treat early, then the complication and maintenance things are more favorable. So I think if we can predict, and the anyone who is in atrial fibrillation should be first. We should have a so I think Dr. Bhatta has a question. Can we have a mic, Dr. Bhatta?
Mic, please.
Thank you. We have many patients of atrial fibrillation, many patients of stroke who come and we can't prove atrial fibrillation on them. Looking at the GLS or the left atrial strain, can we start them on anticoagulants? Is there a guideline or any thought process on that?
I did not touch that topic. Once you develop an atrial strain, you can predict that which patient is going to go on a stroke.
Okay, so can we start these patients on anticoagulants?
I don't say can we start. I didn't say that.
It's not in the guidelines yet. So Dr. Sanjay Mittal,
Yeah, so the similar kind of question, for example, all of these patients were HFpEF. If you have a structural defect, mitral valve, or LV systolic dysfunction, it's a different cup of tea altogether. So the treatment essentially remains the treatment of HFpEF rather than any other drug. There are two, three things. One is beta blockers. The second thing is the thing what Bhatta was mentioning about anticoagulants. These are two things which we still would not use even if we have a high risk of atrial fibrillation. Because the risk of these drugs, there's no proven data to suggest that beta blockers' initial enactment in a suspect HFpEF has any outcome benefit. So your comment on this, even if we have a high suspicion of future atrial fibrillation, the action plan doesn't change.
As far as therapeutic is not going to change for sure about it. And take my words, if you look for these eddy currents in a time to come, study them. Let's see what exactly is happening in these eddy currents. Are they really the formats for future thromboembolic events? That's possible. The answer is going to come.
Yeah, but I would beg to differ from that. The strategy would not change. So the moment you see these things before, you can start. And I think you told also that the remodeling agents, the positive remodeling agents, pharmacotherapy can be started. So they should be on. So we need to study more. There is a lot of data on ACE inhibitors and prevention of atrial fibrillation, statins, and of course now the newer, HFpEF molecules. Like, so the patients who are on MRA antagonists, the ACE inhibitors and all, they would positively remodel the left atrium and would decrease the event. So there is a clear cut data on preventive strategy. So I would say that not as far as anticoagulation, but definitely the remodeling agents can be started to prevent it.
Exact answer is like whatever we could do the best with existing data.
And
That's
the
the
risk
answer.
factor modifications, like if the
Risk factor.
patient has got uncontrolled diabetes, uncontrolled hypertension, all those things can be
I
worked.
just
Yeah, Dr.
one,
Chopra,
yeah,
please.
one just comment is that most of these patients who have a left atrial remodeling, and as we know, LA is very thin. It's very thin, and there is a electrical remodeling also. So we need to focus on remodeling reversal not only at the sarcomere level of the LA but also the electrical level. And I think I totally agree what Viveka you mentioned is remodeling reversal is the answer if you really want to eliminate LA atrial fibrillation reversal.
Excellent. So give a big hand to Dr. Rakesh Gupta and
Thank you.
main